clinicians across the country that they wanted to make sure that they were engaged. So the QPP piece is really targeting those practices that are 15 and less. So back to the 140,000, the last number that I heard in February, I believe, was somewhere around the 90 to 100,000. However, with that in mind, this next year, as we're moving forward, CMS is really focused on supporting those clinicians to transform. So it's about the tools, it's about really, okay, now we've got doctors in, how do we make sure they move forward through the 5 stages of transformation? So it's, getting the word out is still there, but now it's more about, really meeting, helping the doctors get EHR, helping them to understand the quality measures, helping them to pick their pace. It's real tactical, tool-based kinds of things. The first year, it was more, outreach and information. Now it's, we got doctors in, we got to make sure that and they're really very emphatic about that's why they've developed now the QPP website, there are tools there that clinicians can support.
And Jean, would you agree, if we make this work, that's why it's so important that we join in this.
Yes.
Because if we make this work,
yes,
then we can preserve this. This will not get crashed like they did in Indiana. But what's important, this can be a very key part of healthcare reform.
Sure.
And
so this is, team, this is healthcare transformation. It's healthcare delivery systems reform and healthcare payment reform. And so with the, with MACRA doing away and now moving forward with MIPS, this is here. This is not going anywhere. It was bipartisan. I was just on the Hill earlier this week and saying that, that Dr. Price was very pro-MACRA. So MACRA, which is this legislation, is not going away. It's bipartisan. It's right. The work that you're talking about with the administrator, that was on the Medicaid side. That's different than this particular work. Yes, sir.
I practice in Philadelphia, Pennsylvania, and 90% of my patients are in a plan. The Medicare patients are either Keystone Health Plan 65, Aetna 65, or Medicare and Medicaid plans. Very few are got very serious about reaching present. Just have straight Medicare with a 20% provider. So how are we included in this?
So you're basically talking on Medicare shared savings plan.
No, Medicare managed care.
Oh, so you're the Medicare Advantage plan products. And are you in an ACO as part of that process, or just into the contract? And then paying your capitated payments? So, are they dual eligible folks?
A lot of them are dual. They have Medicaid and then plan. Gateway, Cigna, which I still got out of, and Keystone VIP.
As long as you're billing Part B,
it's fee for service, but we pay by the insurance company. We don't bill directly to Medicare.
Do you have any?
We bill directly to the insurance company.
Then there's that.
if it's an APM, but not an advanced APM, still in MIPS. If it's an advanced APM, then it's only
So how large is your Medicare B practice? How large is how many patients do you have that are just Medicare B, or what is the volume?
What's happening in a lot of states, this is happening in Virginia, is that the Medicare recipients are being put into managed care plans.
Yes.
And then your dual eligibles in Virginia have all been put into managed care plans. And so in your small practices, you're not having a lot of individual Medicare pay. I mean, it's dwindling to very, very few who have elected to stay with traditional Medicare. They're no longer traditional Medicare. So I think the question that you're asking is, because of the definition you gave in terms of the 100 patients for Medicare, you're not billing Medicare. You're billing one of these HMO plan, then are they counting you as well with that, or are you, they're not counting?
If you're in one of those plans, and that, even though your claims are going to the plans, if the Medicare recipient is being attributed to your TIN, then basically it's going to be your cost is going to be associated with that special savings.
Well, if I could just add some commentary. The situation where the majority of, or the lion's share of the Medicare beneficiaries are in Medicare Advantage, you may fall below that 30,000 patient threshold. However, this is the big however, the Medicare Advantage plans, many of them, most of the large ones, are mimicking what CMS is doing. So they are developing their own quality payment initiatives that are going to look very similar to CMS, and they're going to have the same reporting requirements. So it really behooves providers to ensure that they are establishing their practices to meet the requirements of CMS, because Medicare Advantage and the commercial plans are going to follow shortly after.
And we saw that 3 weeks ago when we were in Puerto Rico for 60% of the cost in Puerto Rico in those same plans. And they're already developing those outcome plans, but there are MIPS outlier positions, particularly some of those positions that participate in those plans that are part of our health centers, and that are building their ancillary components, especially those in Part B, rather than just the primary care piece. So again, echoing what he said, those measured components are the same components on the MIPS positions. But as part of that process, even APM is going to have MIPS positions that are MIPS eligible, that are going to follow that with some certification levels.
One other thing that I just wanted to share, and that is there's something called the LAN, the Learning and Action Network. It's a CMS Learning and Action Network. And what this is an entity that really CMS with the commercial payers are coming together to really trying to make this so that it's more seamless. So what I want to say to you is that my recommendation to you is that even if you do not, you do not maybe have a large Medicare plan or your Medicare, cadre of individuals, this is still, as JR said, this is a movement, this is here. And so, because we have sometimes doctors will say, oh, I'll just stop taking that plan. Hello, I mean, unless you're going to a straight cash, kind of thing. This is, so, this is quality improvement, this is payment reform, and as my colleagues have said, the commercial payers are embracing many of these same principles. And so if you're transformed, guess what? You're going to be ready in many cases to move forward. So thank you so very much. Please give it our exhibit in the other room. Thank you so much. We're very delighted to be able to support the NMA and its Region 2 meeting here. Thank you very much.
I'd like to thank, this is very enlightening. I think, as someone mentioned, the train has left the station. I think it was Mr. Simpson. And I hope there's a boxcar with some antidepressants. But anyway, having said that, I'd like to give certificates to all the participants. Very excellent, very enlightening. And Mr. Simpson, thank you very much.